Morning, everybody. Happy New Year. Good to see everybody's smiling faces. And it is my distinct pleasure to introduce to you our Chief of Cardiology, whom we successfully recruited away from Rush. He's been here about 3 months. He is a professor of medicine, endowed chair in cardiovascular innovations. He directs the advanced heart failure and transplantation, as well as the fellowship in cardiac imaging. He's an expert in cardiac imaging with multiple board certifications, a stellar training record. He was at one time even an electrophysiologist, so this guy knows a lot about the heart. His focused interest, as you know, is in lipid clinics, which he's established, lipidology and lipid clinic he's established here, as well as infiltrative cardiac diseases. He has hundreds of publications and presentations and is well known nationally and internationally. The thing I wanted you to know about him, he's only been here 3 months and he's already a friend of many people. He is the kind of leader that is an inspirational leader because he loves to teach. He brings people together. He's mentored many, many people. And so if young faculty want to know a pathway to being a division chief or dean or department chair, just watch Dr. Kalra. So with that, I'm going to let him teach us about new guidelines and role of imaging for chest pain evaluations. Dinesh?
Thank you for that kind introduction, Dr. Kruger. You're making me blush, but it's really fun being here. And as Dr. Kruger mentioned, I've only been here a few months, but I've seen nothing but a warm welcome from the people of Kentucky and from my friends and colleagues at the university, so I want to express my gratitude to that before I start. What I thought I would do is today talk to you about chest pain because it's such a common problem, and finally we're seeing some momentum in the United States about approaching this in somewhat of an intelligent fashion. And I wanted to share with you the new guidelines and what we have done in our cardiology division to incorporate those and bring in some of the new technology, such as CT and high sensitivity troponin testing that I'm sure you've all seen it being incorporated into our clinical pathways, and just sort of give you a paradigm as to how to approach this common clinical conundrum, because it can be complex. So I'm hoping at the end of the talk you'll have a better understanding of what to do with these people when you see them. This first slide shows you what's happened over the past 10 years in the way we approach chest pain. So the first sort of guidelines in the United States came out in 2012 from the American College of Cardiology. And you'll see here that the first test they had recommended at that time was a standard exercise EKG. So if a patient could exercise and they had undifferentiated chest pain, they said just do a plain treadmill EKG test to risk stratify. And if that was abnormal, then they would go on for further testing. And in that iteration of the guidelines, coronary CTA and CMR got a lower level of recommendation, which was a class 2. Class 2 recommendation means there's moderate evidence for it, and you may consider it, but it's class 1 is strong. And so CT and MR and other forms of stress testing were below stress EKG at that point in time. Fast forward about 4 years, the National Institute of Clinical Healthcare Excellence, the NICE, which is a healthcare body in the United Kingdom, came out with their own set of guidelines. And by this time, coronary CT was really exploding in terms of clinical practice and evidence, and they gave it a class 1 recommendation for all comers with chest pain. So it didn't matter what your pretest probability was, whether you were low risk or high risk. They said the first test we want to do is a coronary CT, and they implemented that in the United Kingdom. Then a few years later, the European Society of Cardiology came out with guidelines for chronic coronary syndromes, what we call stable ischemic heart disease. And they said, well, all the tests are on an equal footing. We recognize that CT is a great test, but the evidence so far, back in 2019, after some trials called PROMISE, which was one of the trials, and many other trials, they said the evidence base is such that stress testing, CT, MR, all share the same class of recommendation, which was a class 1 recommendation. And so that was our practice everywhere in Europe and in the United States. Obviously, this was driven in some part by local availability as well as healthcare economics. And then 2 months ago, the American College of Cardiology revised its previous 9-year-old guideline to come up with a completely new guideline that's been revamped. And they now gave coronary CT a class 1 recommendation, but with a level of evidence A. That's the strongest level of evidence you can have from multiple high quality randomized controlled trials showing the strength of that modality. Now, if you look at this chart, you'll see stress testing also gets a class 1 recommendation, but the level of evidence isn't as strong as that was given for coronary CT. So what I thought we would do today is dissect out what the evidence is, what should you do when encountering these people in practice, given all these divergent guidelines. So why was a change in paradigm needed? Well, there were 3 main reasons, right? So first of all, we began to recognize that in the US, the majority of chest pain that we see is actually not cardiac or coronary. So the prevalence of finding obstructive coronary disease when encountering somebody with undifferentiated chest pain is only 10%. So it's such a common problem, but if you evaluate it, you often don't find the disease that you are actually looking for. There's multiple other causes of chest pain, as we'll talk about in a second. Second was that the rates of invasive angiography or cardiac catheterization that showed normal coronaries or no significant coronary disease were unacceptably high at 50 to 60%. And what that means is when you take a patient to the cath lab and at the end of it you say, Mr. Smith, good news for you, we didn't find any blockages, and everybody's celebrating and high-fiving out there, well, take a step back. How would you like to be that patient and say, well, I got stuck in my groin or my wrist, all to see that everything was normal? Why couldn't you tell me that beforehand? Why did I have to undergo an invasive intra-arterial procedure just to hear I don't have any disease? So that was what led to some of this new technology and changes. So this is a seminal study shown at the bottom in about 400,000 patients published in New England Journal in 2010, showing that of 62% of patients who had positive stress tests, when you took them to the cath lab, they had no actionable obstructive coronary disease. But even worse, perhaps, 38% of patients who had negative stress tests, who further got evaluated with a cath at some point because of persistent symptoms, did actually have obstructive disease. So we missed those patients. And furthermore, if you look at the bar chart on the right, it shows you that I'm getting a little bit of an echo. I wonder if someone else has that too. Sorry, I'm just going on. Okay, so it's gone now. If you look at the bar chart on the right, it shows you that the performance or the probability of finding coronary disease was no different, whether your stress test was positive, negative, equivocal, or even if you had no test at all. So the bottom line was that we needed to do better with our stress testing strategies, and we weren't quite getting exactly what we needed in terms of performance on these stress tests. The third reason was that the pretest probability we'd been using from prior studies in the 40s and 50s when people ate a lot of egg yolks and bacon and smoked and were unhealthy, and the whole concept of cholesterol and statins was not known. We were using those pretest probability tables that was 50 years old, and they were outdated, and they overestimated our probability that somebody would have coronary disease. So if you look at this chart, in your 30s and 40s, the pretest probability of finding somebody with obstructive disease is way less than 50%. And the only people who have a higher than 50% chance of having obstructive disease before you order the test are 70-year-old males who have classic chest pain. Now, you can refine some of this by doing a calcium score beforehand, such that if you have a prior chest CT for whatever reason that shows the extensive coronary calcification, or the patient's had a calcium score and it's a very high calcium score, then that bumps up the patient's probability of having coronary disease. But short of that, the vast majority of patients are going to have a low pretest probability. And so for the first time, these new guidelines incorporate calcium testing as a way of reclassifying patients in terms of probability. And second, what they do is they say, if your patient is really low risk, you may choose not to test them at all. This is a new concept because in the United States, with all the medical legal climate we have, every primary care doctor feels like if somebody comes in with chest pain, they either got to send the patient to a cardiologist or do something about it and get a stress test. And this is a sort of disruptive way of thinking that if your probability of chest pain is because you're 30 years old and you're a woman and you have very atypical symptoms, you can choose to defer a stress test. So the knee-jerk reaction shouldn't be, I need to do something. You can elect to wait and watch. And if the patient continues to have persistent symptoms, only then you should proceed with testing selectively. So it's okay to be judicious about it. And if your pretest probability is more than 15% after you use the stable, so you have a 50-year-old man who's got chest pain or dyspnea, then you can proceed with testing. And testing has been shown to be beneficial in those instances. So if you look at what kind of stress tests we have what kind of testing we have two major categories. We have functional tests and anatomical tests. And I'll show you some examples of this. In the functional tests, obviously, you have stress echo, you have nuclear testing, you have PET, which is a form of nuclear testing. We have cardiac MRI. And then you have anatomical tests that actually look at the coronary arteries themselves, and that includes a CT as well as CAT, invasive angiography. And the sensitivity and specificity of these is quite different. As you can see, exercise EKGs doesn't have a great sensitivity, and it's got a moderate specificity of about 70% or so. And CT has excellent sensitivity because it's almost impossible to miss coronary disease on CT because you're looking at the vessel wall. And so it's got great sensitivity, but the specificity for all these tests is somewhere in the ballpark of 70 to 80%. Now, we've done additional things to bump up the specificity, and I'll show you that in a second. So we actually wrote a review on this. How does a clinician decide which tool to use for what purpose? And I know it can be confusing. So what I'm going to try to do is take you over the next few slides is to give you the strengths and pitfalls of these tests and tell you which one is best suited for what purpose. So I know we got too many options. It almost feels like we need a cardiology consult for every case to dissect out every case of chest pain. But at the end of this, you'll be able to determine which test is perhaps best for your patient. So the first test I'm going to show you here is called SPECT MPI. This is your classic nuclear stress test. Some of you know this as thallium nuclear or cardiolite nuclear. What we do here is we inject a radionuclide into the patient's vein and get images at rest. And those are depicted in a tomographic manner. So this donut you're seeing is a cross-section of the left ventricle being sliced from the apex to the base of the heart. And after some time, we give a vasodilator or have the patient run on a treadmill and re-inject the radionuclide, which goes and binds to the myocardium in proportion to their blood flow. So this orange donut you're seeing actually depicts what's going on in terms of perfusion of the left ventricle. And then we compare the stress images shown up top to the rest images. And if you see here, those arrows show you that a portion of the left ventricle, here the anterior wall, is not getting enough blood supply. Hence, you must be dealing with a stenosis, and you can quantify that. That's 10% of the left ventricle has moderate anterior ischemia. And on top of that, this test allows you to get ejection fraction of the heart and as well as wall motion, which give you additional prognostic information in terms of what's going to happen to this patient down the road in terms of coronary events. Now, does the ischemic burden portend prognosis? And we always used to think, yes, it does. So if you had a patient with more than 15% of their left ventricle being ischemic, we said, this is a patient in great myocardial jeopardy, and we should do something about this patient. And this observational data, which was published in the 1980s, actually showed that revascularization improved outcomes once your myocardial ischemic burden exceeded about 12 to 15%. So we would classically refer these people for revascularization. On the other hand, if you had a small amount of ischemic burden, you actually did better with medical therapy, and revascularizing people with either stents or bypass if they had less than 5% ischemia was actually detrimental because of the upfront procedural risk of doing that. Now, the caveat was this was all observational data. It wasn't prospective randomized data. And this concept, which seems so intuitively appealing, has been flipped now in the sense that the latest trial that I'll talk about in a minute failed to replicate these findings, which is shocking to the cardiology community because we always felt ischemia portends prognosis. Well, it does, but perhaps even a bigger driver of prognosis is your atherosclerosis burden. And that's why CT has become more important now, because you can actually see coronary atheroma with CT. Now, revascularization, as you know, CABG provides a survival benefit if you have left main stenosis or triple vessel disease, especially if the proximal LAD is involved, or if you have a low ejection fraction, especially in diabetics. This has come out of large trials in the past. Now, PCI, surprisingly, and this is a thing that I reinforce every time I give a talk on ischemic heart disease, has zero survival advantage. You will hear doctors talk to their patients say, we did the stent and we saved your life. That is factually incorrect. There is no data showing that PCI or stenting provides you a survival advantage or a reduction in myocardial infarction. What it does is it provides you better symptom relief than medication. So if somebody's having angina, they're a young, active person, and you want them to get angina relief, PCI does a better job than putting them on oral medications, but it doesn't protect them from a heart attack or provide them longevity. So that's an important concept to remember. Along the lines of SPECT is another modality called PET, which uses a different radio tracer called rubidium. Why is it better than SPECT? Because it's got better spatial resolution. So you're able to see things in finer detail. It's a faster test. Instead of taking 3 hours, it takes 15 minutes. What that means to your stress lab is they can image more patients a day. Patient throughput is faster. But this biggest advantage is that you can actually calculate myocardial blood flow and calculate myocardial blood flow reserve, so you don't miss something called balanced ischemia. On SPECT testing, you could potentially miss somebody who has three-vessel disease and all portions of the heart have equally reduced perfusion. You do not miss that with PET, and you can also diagnose something called coronary microvascular disease, what's called syndrome X or microvascular angina that some middle-aged, healthy, otherwise healthy women seem to have. So that's why it's a better test. Stress echo, on the other hand, has been around for about 30 years. It's well established. It's a simple test. Anybody can do it. It's widely available. It's cheap. However, it's a little bit less sensitive. So you need a higher ischemia threshold to be able to detect a wall motion abnormality. And it can actually miss portions, ischemia and portions of the heart that are posterior just because of poor visualization of that portion. However, it allows you to see other structures of the heart. So you can look at the pericardium, the valves, and pick up incidental pathology that can also give rise to chest pain. This iteration of myocardial contrast echo requires giving intravenous contrast that appears bright on echo. It fills the cavity as well as it perfuses the myocardium. So you'll see this portion of the heart appears black, and this portion of the heart has a speckled sort of white appearance. That means this is getting bubbles of contrast flow through the myocardium, and this portion isn't. So you can use that to also say that, yes, there's a stenosis supplying this wall of the heart. This brings me to the concept of ischemic cascade, which tells you how much ischemia do you need to have before a test becomes abnormal. So if you have somebody with mild disease, mild obstruction, or microvascular ischemia, you need a more sensitive test like PET or MRI to pick up that ischemic burden. Whereas the more stenosis that you have, the other tests start picking it up. So for example, a CT scan can look at plaque directly. PET, and as I mentioned, is not as sensitive. Even less sensitive than that is echo, because you're looking at wall motion. And finally, once a patient has tremendous amounts of ischemia, your EKG becomes abnormal. So whether it's resting EKG or treadmill EKG, It's one of the least sensitive tests and the last one to appear as symptoms. So by the time a patient has chest pain symptoms, they have a significant ischemic burden. And so it's important to kind of visualize this ischemic cascade when you're thinking about whether you want to balance sensitivity or you want to only pick up actionable ischemia that is very, very severe. MRI, again, relies on the principle of giving gadolinium contrast and then looking at the myocardium to see perfusion. Here you'll see areas that appear darker, so-called hypo-enhanced or hypoperfused. The anterior wall and the inferior wall in this patient is ischemic. But the beauty of MRI is that it's a one-stop shop. So it's the gold standard for looking at ejection fraction, volumes of the heart, looking at scar. Here you'll see this white structure on late gadolinium imaging is scar. It's the best test to look for scar, and scar gives us a lot of information on prognosis of the patient. And it's also great for picking up other conditions such as myocarditis. We've seen a few cases of COVID myocarditis that appear with chest pain. So not everybody with chest pain, as you know, has coronary blockages. There's many other causes of chest pain, including pericardial diseases, masses, etc. So for that, you want to be looking at things that look outside of perfusion. You want to look at the heart structure, function, other things in the chest that can give rise to chest pain. Sadly, in the United States, because of reimbursement factors, no other factors, the utilization of cardiac MR is tenfold less on a per capita basis than the United Kingdom. And we're hoping this will change with time as reimbursement patterns change. And lastly, we'll talk about coronary CT. The rest of my talk is going to focus quite a bit on coronary CT. You'll see here that there's an excellent correlation between CT and invasive coronary angiography in terms of picking up plaque burden and stenosis. But just like MRI, you pick up other stuff on CT that you would have missed on, say, echo. For example, you can pick up pulmonary emboli, or somebody with pneumonia that's having chest pain, or an aortic dissection. You can also evaluate grafts. So this is a saphenous vein graft coming from the aorta that's completely blocked. And so things like this are harder to see on echo or other tests. And so CT is sort of a more comprehensive evaluation of other things that can lead to chest pain, but it's also one of the greatest tests for coronary atheroma visualization. The caveat is that it requires experienced readers. So when CT first started in 1998, folks were overcalling degrees of stenosis based on the calcification burden. But as the technology has matured, that problem has largely gone away now. One of the other things I want to introduce to you is this concept of something called fractional flow reserve. This is a concept in coronary physiology, whereas if you're trying to assess whether or not a stenosis in a coronary artery is hemodynamically significant, i.e. it is reducing distal myocardial perfusion, you can insert a thin coronary wire into that coronary artery and administer a vasodilator such as adenosine, which dilates the blood vessel, increases blood flow about fourfold, and then gently withdraw your wire while measuring pressure. So if you have a pressure drop across that lesion, such that the ratio of the distal pressure to the proximal pressure is less than 0.8, it tells you that lesion is producing ischemia. So in fact, CMS guidelines and reimbursement guidelines require that when you do a cath on somebody, if somebody has an intermediate stenosis, like 60 or 70%, you should be able to prove that that lesion is actually ischemic, because 60 or 70% is in the eyes of the beholder. Some people may say it's 50, others may call it 80. So how do you know that lesion is actually causing myocardial perfusion abnormalities? This is one way to say that. If you have a stress test beforehand showing myocardial perfusion abnormality, great. Otherwise, in the cath lab, you can do this concept of FFR to show that the FFR is less than 0.8, there's a pressure drop, and hence that lesion is significant, and that justifies you revascularizing it with a stent. Now, that was an invasive FFR. It's difficult to do a 3-vessel invasive FFR. So this really cool concept has come about, which uses computational flow dynamics. This models pressure drop based on something called Navier-Stokes equations that have been used in fluid dynamics for about 50 years, and those are the kind of equations airline pilots and physicists use to talk about pressure drop on the wing of a plane or when a vehicle is moving in a body of water. So you can use your typical CTA without any changes to the CT images you've gotten on a patient to get this FFR value. And so, I do a CT today. A month later, I want to talk about, is this lesion significant? I can feed this CT into a computerized system, a supercomputer that gives me FFR values that are modeled based on artificial intelligence in all 3 blood vessels. And this is impossible to do on CAT just because it's not practical to put in coronary wires in all 3 blood vessels and withdraw them. It carries a risk of complications. This is a tool that allows you to get FFR at any point across in the entire coronary tree just on the standard CT images you've obtained. And again, just like invasive FFR, this CT FFR value of less than 0.8 tells you your lesion is ischemic. So now what's happened is you have anatomical images of stenosis, and on top of that, you've overlaid a concept of physiology, i.e. you have a 60% lesion you're seeing on CT, and you say, is this lesion going to be hemodynamically significant? Well, let me check the CT FFR distally, and if it is, for example, here you have a lesion that's like 60 or 70%, the distal FFR is low, it's less than 0.8, so hence this lesion is significant. Here's another example of it, is an 80% LAD stenosis that you're seeing on coronary CT, and all of this shown in red tells you that the FFR there is low, and then you take the patient to the cath lab and you're able to see that same stenosis you saw on coronary CT, as well as justify revascularizing this lesion. Now, somebody has done a study, this is Norgard back in 2015, where they pooled data of all the kinds of tests we had, stress echo, SPECT, IVUS, MRI, and came up with what gives you the best sensitivity and specificity compared to invasive FFR, which is the gold standard. And this showed that the combination of CT plus CT FFR, so it's really one test, but the information you're getting from that is the best test in terms of diagnostic performance. So that's become an important concept. When we do a CT, we're able to do CT FFR, and that's a technology we're in the process of acquiring. We should have it here in about a month or so. Another concept we talked earlier about calcium scoring. Calcium scoring is used predominantly for risk assessment, but it's also now in the guidelines to help differentiate people who are at higher risk versus lower risk. So if you get somebody in the office and they have stable chest pain that's been going on for months, you're not very convinced it's cardiac, and you say, well, let me see, this patient had a chest CT for some other reason 2 months ago. And you take a look at the chest CT and there's 0 calcium there. Calcium equals atherosclerosis in the coronaries. If there's 0 calcium, now you've dropped that patient down to a lower risk bucket because you're saying, well, if there's no calcium and the chest pain's atypical and they don't have a lot of risk factors, I'm comfortable just watching this patient. So that's become a new concept of using calcium scoring for risk stratification, not just for risk prevention, but also for patients with stable chest pain, not acute chest pain. You have somebody in the ER with chest pain, that's a different ballgame than somebody who's in your office and having chest pain for months and months. Now remember that plaque in the coronary arteries is only about 1/5 or 20% of it gets calcified. So what you're seeing on a calcium scan is just the tip of the iceberg. This other plaque, which is non-calcified or what we call soft plaque, you can only see with other technologies such as intravascular ultrasound or by doing something called a coronary CTA. The difference between coronary CTA and calcium scoring is that in a coronary CTA, we're actually injecting iodine contrast into the vein and taking a look at the entire vessel, including the lumen and the wall of the vessel. Calcium scoring is 0 contrast. It's just a plain non-contrast, quick chest CT. So all we're seeing on calcium scoring is this, there's no contrast, but we're just picking up calcium. And then you compute the amount of calcium and you tally it up in all 3 blood vessels, and you get something called the Agatston score. And the reason the Agatston score is important is because it tells you the probability of having severe stenosis. So this is data we published back in 2014. showing that if your calcium score was over 400, you had a 40% probability of having at least one stenosis that was 70% tight or more. And this is an important concept because people conflate the two. They think if the calcium score is high, you have severe coronary disease. That's not the case. You have a 40% probability of having severe coronary disease, and you could do further testing, but it does not equate to having obstructive coronary disease. It just raises the probability that you do. Now, calcium scoring is wonderful for prognostication. As you saw in the previous slide, once your calcium score is high, your probability of having a cardiac event, major adverse cardiovascular event, you'll see this term all the time in cardiology literature, MACE. Your probability of having MACE is high. So once your calcium score is more than 1,000, you have a 40% chance of having either a heart attack or dying in the next 10 years. So that's why when we see calcium scores on CTs, we start people on preventive therapy because we're trying to prevent downstream events from happening. One of the things I like to emphasize is the difference between CT and invasive angiography. So shown here is a cath or an invasive angiogram where you inject iodine dye into the blood vessel and you take a look at that blood vessel. The pitfall of this technique is that you're only seeing the lumen of the vessel. You're unable to see the wall of the artery. And in order to see the wall of the artery, you need this technique, which is IVUS. So you're putting a catheter that's able to emit ultrasound waves into the coronary artery and look at the wall of the vessel. So here you see the lumen, and then you see this speckled white structure that is the atheroma, and then you see the wall of the vessel. So atheroma can be missed on invasive angiography. And you say, well, that's so strange. Why? Because you're only looking at the lumen. And this phenomenon by this Russian pathologist by the name of Glagov demonstrated that. So when you start getting atheroma in an artery, what does the artery do? It expands outwards. It's a compensatory mechanism to preserve the lumen. So you can have tons of atheroma, and the vessel is showing positive remodeling or outward expansion to try to preserve the lumen so the heart's getting blood flow. It's only when you get tremendous amounts of atheroma that it starts to impinge on the lumen, and that's when you start to get stenosis. And so by the time you're seeing stenosis on invasive angiography, you have a tremendous burden of atherosclerotic disease, and you're only seeing the lumen, which is why this patient's invasive angiogram looks normal. But if you look at the CT angiogram, which is able to see the vessel wall, in addition to the lumen, you'll see there's tons of plaque and tons of atheroma. So the beauty of CT is that not only sees the lumen, it looks at the vessel wall where atheroma is accumulating, so you get a more comprehensive picture of what's actually going on. And the prognosis, as I told you, is determined by your atheroma burden, not solely by the degree of stenosis you have. And so that's, taken us to this concept of CT scanning. And these days with modern scanners, we can do scans at minuscule radiation, 0.2 millisievert radiation, which is less than a mammogram, less than the background radiation you get every year, and you're able to see all three coronary arteries within a 1-second scan. A single heartbeat scanner can get all this information with very little contrast. And so I want to thank John Walsh and Tom Miller for being very forward-thinking and helping us get this CT scanner that we're going to be getting this summer, and we'll be able to do top-of-the-line CT scanning with plaque characterization in all of these patients. And this concept is important because looking at plaque has taught us that most myocardial infarctions do not occur in 90% stenosis. They occur in stenoses that are less than 50%. And why is that? Because plaque can be unstable. So you can have a 30% stenosis that has a very thin cap, and because of enzymatic activity going on in that plaque ruptures one fine day. Thrombus accumulates on top of the plaque. It causes 100% sudden occlusion, and you end up having a myocardial infarction. 90% stenoses give you stable angina. It's the 30%, 40% stenosis that ruptures and causes a heart attack. And that's why most people who come into the hospital with heart attacks do not have prior risk factors that would have necessitated treatment. So unless you do a CT angiogram to characterize those non-obstructive plaques, you've lost a window of opportunity to institute preventive treatment in these patients. And that concept is illustrated here. You see the CT, and you see tons of plaque shown here in black, which is soft plaque. This is calcific plaque. And you look at the cross-section of this, you can see clearly there's so much plaque surrounding this lumen. But if you had taken this patient on angiography, cath, invasive angiography, you would have said there's only mild stenosis. Stenosis is not the be-all and end-all of what we're looking for. We're looking for plaque. And so things that increase the risk of acute coronary syndromes down the road are something called low attenuation plaque. So if you have very lipid-rich plaque, that causes heart attacks. If you have spotty calcification, areas where plaque is ruptured, caused healing, you get tons of spots of calcium, that's a bad sign. If you have positive remodeling, where you have a ton of atheroma that shoved itself in the vessel wall, all of those are bad prognostic features that you have what we call vulnerable plaque that's going to cause downstream heart attacks. And so we try to prevent those with starting people on statins and other therapies, as I'll show you in a second. So this concept of mild coronary disease is actually a misnomer, because if someone has 3-vessel mild coronary disease that, you go for a cath, they say, oh, there's mild CAD, that's fine, you're okay, go home, nothing to do. Your mortality is 6-fold higher if you have mild coronary disease as opposed to if you have normal coronaries. And that's an important concept that's come about in the past few years. Along that concept is this seminal trial that was reported in New England Journal in 2018, where what they did is in Scotland, they had 5,000 patients that they randomized to coming in with chest pain to their primary care doctor's office. They said, we're going to do standard care, which in Scotland was stress EKG. Some of these people got stress nuclear, or they got standard care plus coronary CT. And for the first time, the addition of an imaging test was able to demonstrate a 40% reduction in the rate of coronary heart disease death and myocardial infarction in these people. If you think about it, that's the first time an imaging test has actually changed the prognosis of a patient in coronary heart disease. This was a seminal trial, and this is what led to a change in the guidelines, that the addition of coronary CT allows you to not just pick up stenosis, but it allows you to document non-obstructive plaque. Now think about it. When somebody gets a nuclear stress test, you're not looking at plaque. You're just looking at perfusion. And unless there's a stenosis of more than 70%, the report is going to say normal perfusion. And the patient says, okay, well, the doctor sees the patient and says, well, you don't have blockages, go home. He's not a cardiac patient. He just goes home. Whereas when you get a CT and you see non-obstructive plaque, you say, wait a second, you got tons of plaque, we're going to give you aspirin, we're going to give you statins, we're going to give you other therapies, control your blood pressure, have you watch your diet. And those things are the ones that reduce myocardial infarctions down the road. So that's the value of visualizing plaque. And that's what led to this guideline, which came out 2 months ago, that they came up with a catchy acronym about chest pains and how to evaluate it. And we'll talk about some of this stuff, the incorporation of high sensitivity troponin, the knowledge that women are more likely to have unusual symptoms such as dyspnea or sweating or anxiety or dizziness. So we've, in the past, well documented that women are often discharged from the emergency room with, other alternative diagnoses such as anxiety. So don't disregard these other symptoms in women. And then this table, which I'm not going to belabor here, talks about the multiple other causes of chest pain, which you can go over. But I just want to draw your attention to a few important concepts in this paper. The first one is that they want you to think of chest pain as cardiac, possibly cardiac or non-cardiac. Get rid of the terms typical or atypical. So you want to classify chest pain in that form. The other thing is you want to get rid of this term, which I see everywhere. I misspelled it, troponinemia. There is no troponinemia. You either want to say there's a non-STEMI, type 1 or type 2 demand or plaque rupture, or you want to say acute or chronic myocardial injury. Now you want to characterize what you think is the process going on in the coronary arteries rather than just saying there's troponin in the blood. We know there's troponin in the blood. We want you to think beyond that and say, are you thinking this is plaque rupture, or are you thinking this is myocardial damage from a virus like COVID? In that case, it would be acute myocardial injury. It's different from an infarction. Infarction requires you have a process in the coronary arteries that caused occlusion, so you get ischemia and you get a rise and fall in troponins. That's the definition of infarction. If you get a chest contusion and you damage myocytes from that reason and you get troponin leak, that is acute myocardial injury. So it's important to use correct terminology, and this guideline talks about that. Then it talks about which kind of stress test to use. I've given you a flavor of the kind of stress tests that we have, but it's also important to see where you're practicing. If you practice in a little town where MRI is not available, then use the test you're comfortable with and that your readers have expertise in. I think that's important. We have the fortune of working in a big university setting. We have cardiac CT, we have cardiac MRI, we can do all these tests. So look at who's reading the tests, what's been your experience with those tests, and use your judgment to pick the test that best suits the needs of your patient. There are obese patients for whom stress echo may not be the best test because you can't see the heart. MRI may work great over there. And there are patients who are very high risk. In that case, going straight to a cath may make sense. So all those things are incorporated into those guidelines. And then it talks about the utility of CT, which I've spoken about with the class of recommendation 1, level of evidence A. And then if somebody has a STEMI or non-STEMI, they clearly benefit from a cath, but there are other high-risk features on tests that will push you for a cath. So if somebody has very proximal, nasty-looking LAD lesion on CT, or they have a nuclear test that shows more than 20% ischemia, then you can go forward with a cath. And so these tables are all given, they're flow charts. I won't spend too much time going into details of this because this is more for our cardiology fellows and practitioners, but I want you to have the concepts up front that there are various kinds of tests available, and you won't be wrong ordering a CT as your first line test or a stressed MRI or stress nuclear. Just remember that there's pitfalls of some of these tests. As I told you earlier, they've also incorporated the concept of FFR CT, as I talked about, for lesions that are intermediate. Just because you have a 50% stenosis, that doesn't mean it can't lead to downstream ischemia. Some of those can. And so it's important to recognize that and test accordingly. Acute chest pain is a completely different ballgame. We obviously want to get EKG. We want to make sure there's no ST elevation. If there is, follow STEMI guidelines. There are other things that give rise to acute chest pain, such as acute aortic syndromes, pulmonary embolism, myocarditis, etc. And for the first thing, they've advocated for acute chest pain, and this is something we've just incorporated into our clinical pathways in the past month, is the use of high sensitivity troponin. And the reason that's important is because it's so sensitive that you won't miss any people. So the negative predictive value is extremely high, but you need to use clinical judgment again. So if somebody comes in, like I said, after a motor vehicle accident and they've hurt their chest with their steering wheel, you may get a bump in high sensitivity troponin. That's normal because they've hurt this myocardial contusion. If somebody is 50 years old, doesn't run marathons in the past, and all of a sudden decided to be a weekend warrior and ran a marathon, they may come in with a slight bump in their troponin. So it's important to see first troponin, what happens to the second one, and if it's going up, if the delta is high, more than 15, then you need to observe that patient or call cardiology, especially if they have a high heart score. Heart scores give you a pre-test probability of having coronary disease, just like we talked about. So this algorithm is very useful, and I would suggest you use it. One of the other things they talk about in these guidelines is something that's been ignored in the past, which is ischemia with normal coronary arteries, so-called normal coronary arteries. So you get these women who go to the cath lab and they're told, well, your coronaries are clean, you don't have chest pain from a cardiac cause. That's not true. People can have chest pain from vasospasm. They can have a chest pain from something called coronary microvascular disease, CMD, which can be detected invasively in the cath lab or by using tests such as PET or MRI. And so that's an important concept too. So going back to CT, it allows you to not only characterize plaque, it allows you to determine the amount of stenosis. Here you see there's extensive soft plaque that's causing a 50 to 69% blockage. Here you see a 90% blockage from soft plaque. And so you can couple the degree of stenosis and the degree of plaque with your intensity of therapy. So obviously lifestyle changes are for everyone. Addition of antiplatelet therapy these days, if someone's diabetic, you want to choose a GLP-1, which reduces atherosclerotic events. As we have ezetimibe, we have bempedoic acid. I use all of these drugs in my lipid clinic commonly. Rivaroxaban reduces cardiovascular events, as does colchicine. So we have a whole plethora of drugs, Vasipa, anti-inflammatory drugs, PCSK9 inhibitors. So the concept is to marry the risk somebody has with the intensity of medical therapy. It's not just give a statin and forget about it. You want to tailor how aggressive you are to the amount of plaque they have. This is an important trial that you might hear about, something called the ischemia trial, which was looking at people who had ischemia on stress testing and were randomized to medical therapy, which is so-called conservative strategy, or invasive strategy, cath and then revascularized. Everybody got a blinded CTA. The reason to do a blinded CTA was to rule out people who had so-called stress tests that were abnormal but did not have any obstructive disease. And actually 21% of these 5,000 patients in the trial did have that scenario. And it was also to rule out left main stenosis, because if you're just going to treat people with medications once they have an abnormal stress test without doing a cath or some sort of imaging, you want to make sure you're not missing left main, where CABG provides a survival benefit. So it was a well-designed trial run by the NIH, and the findings were very surprising to all the cardiology community. There was no difference between medical therapy or invasive strategy, cath as the first line. And the reason for this is, again, because you cannot change the prognosis of someone just by doing stenting. Medical therapy these days has come so far ahead that the main determinant of prognosis, once everybody is on statins and aspirin, et cetera, is for people who have extensive plaque, you get benefit by aggressive therapy. And outside of that, invasive therapy only helps if you have angina or you have those select things we talked about: pre-vessel disease with diabetes, low ejection fraction, or left main disease. So I think those concepts are changing now, and so it's important to be cognizant of the fact that it shouldn't be a knee-jerk reaction that stenosis in a mid-circumflex equals the need for a cath, equals the need for a PCI. That's not true. So why will CT increase with time? To rule out left main disease, to diagnose obstructive disease before you take people to the cath lab. You don't want to be using your cath lab for normal cases. You want to be efficient in your cath lab, use it for people who actually need stenting. You should have a roadmap of what you're going to do before you go to the cath lab. You should know where the lesion is, what you intend to fix, will this be fixable? All of that information can be gotten by CT even before you take the patient to the cath lab. To inform prognosis, as I mentioned, anatomic burden of atheroma is more important than ischemia in future events. And of course, to serially evaluate plaque progression, we're starting a trial now that will look at high-risk populations, compare baseline plaque burden to plaque burden on medical therapy at 5 years, and see if we can make a difference with aggressive treatment. So you'll be hearing about that trial enrollment in the next few months. So these concepts are also amazing. We're changing how we used to think about coronary disease and atherosclerosis. I have some time left. I'm going to go over a couple of cases, and then after that, I'll take questions. So let's just do one or two cases. Here's a young man who presented to the ER with chest pain. He had a history of cocaine use. So he's got a worrisome EKG. There's ST elevation as well as biphasic T waves here. So what would you do next? Urgent cath. His troponins are negative, and he's chest pain free now. Or would you do a stress test, or would you do a CT? I think you know the answer here. We did a CT. We elected to do a CT. It wouldn't be wrong to do the other things. I don't think he would need an urgent cath unless he had persistent ST elevation or troponin elevation. And so this was a quick CT done in the emergency room. It shows you left main, left anterior descending. They're clean, pristine arteries despite his use of cocaine, which can cause accelerated atherosclerosis. But he had no atheroma. Circumflex is clean. His RCA was clean, so he was discharged. One of the what trial data has shown us in CT in the emergency room is it reduces your length of stay. The hospitals have started to embrace the use of CT for acute chest pain evaluation. There's a second woman who is 46 years old. She was referred for a stress test due to some atypical chest pain. So she was a big woman. She couldn't exercise. She underwent a dobutamine echo, which causes increased contraction of the heart. And you want to look for wall motion abnormalities. During the echo, she developed VT and had ST elevation. So we knew we were dealing with a problem. So we took her to the cath lab. She had inferior akinesis on the echo. You see these ST elevations inferiorly. Now the left system was normal on cath, and the RCA looked normal, but we couldn't engage it properly. The catheter wouldn't slip into the ostium of the RCA. So we knew we might be dealing with an anomalous artery, and we did a CT, and you can see that RCA is not arising from the right cusp where it should come from. It should come from here, and this is the left main. Instead, the RCA arises from the left cusp, somewhere around here. And the reason that's a problem is because now it travels between the aorta and the PA, so it has a chance of getting compressed by the aorta and the pulmonary artery when the heart has a fast heart rate or is contracting more, or the cardiac output's higher, as happens with dobutamine. And so this vessel gets compressed. These vessels often have a slit-like ostium because of the way they take off. So this lady underwent bypass surgery, surgical correction. CT is a class 1 indication for evaluation of coronary anomalies. This was a fun case that we published a few years ago. MRI, this is a 62-year-old man who saw me because of syncope. That's all he had, and he was a smoker and hyperlipidemic, so we got a stress MRI. You see he has multiple perfusion defects. He was taken to the cath lab. Even though he had no chest pain, he had triple vessel disease, and so he underwent bypass surgery. As I said, bypass surgery helps people with 3-vessel disease. The other utility of MRIs and diagnosis of coronary microvascular dysfunction. And my last case is a 21-year-old who had sex and then had chest pain after intercourse. That was severe. She had severe dyspnea. Troponin rose to 16. This happened, I think, while COVID was going on, so everybody was, could this be COVID myocarditis, whatever. But since she had a troponin rise, we took her to the cath lab, and you'll see the coronaries were okay. The left was fine. The right was called normal, and so we were perplexed as to why she had a troponin bump. Does she have COVID myocarditis? So we did an MRI on her, and you'll notice that the inferior wall is not contracting. It's just sitting there. And we knew there was a wall motion abnormality, so we did sophisticated testing. This is something called stir imaging, which looks for edema, and she had scar in that wall. So we like, something is going on here. This lady's either had occlusion, an embolic infarct, or something else was going on. So we took her back to the cath lab, and you'll see here there was a thrombus in that posterior lateral branch that was missed on the initial cath. So she underwent thrombectomy and heparin, and she did fine after that. So that was my last case. I'll stop here and take questions now.
Oh, Dr. Kalra, outstanding. I don't know what else to say. It's like outstanding. So I don't know if Dr. Kruger, if you want to start off with a question, if for Dr. Kalra, and then we'll let everybody else kind of filter in.
Well, I can tell you, I feel like I've been adequately schooled because I learned things I really did not know, and I always enjoy being able to learn. Particularly, I never knew that coronaries would dilate, so you could have, atheroma and not see a stenosis. I liked the physiology of the flow, fixation, reserve, the FFR. I see Dr. Slaughter on appreciative that realizing that as the chair of cardiothoracic surgery, his colleagues will probably be doing more bypass surgeries by utilizing the technology of cardiac CT. So thank you for increasing our knowledge of understanding. The other thing, you're correct. We think a normal coronaries mean normal, and they don't. And I think you brought that up multiple times, that somebody with risk factors still needs to have lifestyle modification, and we can't use just a single trip to the cath lab to mean, oh, I'm okay, go home. And I think the residents need to listen to that, because, the people that take care of the patients really rely on the expertise, and we can't overly rely on one modality that is not as predictive as one would expect. I guess my question though is, why do we do so many PCIs and not then, is this a knowledge gap that we just don't know? Because there's lots of caths done and lots of PCIs. And you're right. I think I was aware it doesn't improve your mortality, but we're kind of missing the boat therapeutically if we don't do more.
You're absolutely right. Unfortunately, in the United States, the utilization and the implementation of most of these technologies is driven by reimbursement patterns. And it's very sad to say that, but that's not necessarily the case in Europe or the UK or some of the other countries where the national health systems set the agenda and what will be paid and not paid. So some of it is the evolution of data, some of it is just intuitive thinking, which turns out to be wrong. So all along we thought if you had a blockage, you had to fix it. And we would call that the oculostenotic reflex. And people who benefited financially from the oculostenotic reflex tended to do more of it. But now I think that paradigm is changing where we're getting a global comprehensive view of what are we trying to achieve. Are we trying to achieve increased survival? Are we trying to achieve increased quality of life? And if so, have a nuanced discussion with the patient. You have a 50% blockage. What's going to help you is background medical therapy so that doesn't rupture and cause a heart attack. Since you're not having angina, we don't need to address this with a metal tube in your artery, because that metal tube may open up that vessel at that point and make it 0%, but all those other plaques in your other vessels that we're not seeing or caring about, one of those is going to rupture down the road and cause a heart attack. So that's the comprehensive assessment we've started to incorporate these days. So I'm glad you brought that up. I think the paradigm is changing with these sort of guidelines and the thinking.
This is Garbi Sohi. I think it was wonderful, gratifying review. I'm hoping that our cardiology faculty and the fellows were listening to it. I applaud him for reviewing this topic. It was really wonderful. Thank you.
Thank you.
This is
Mark. Oh, go ahead.
Yeah, go ahead, Mark. Go ahead.
So just real quickly, as anticipated, outstanding presentation. And I found it very refreshing that facts are facts. And the idea is that, they shouldn't be influenced or reinterpreted by reimbursement schemes. But I have sort of two questions for you. The idea of FFR, for us, when it comes to bypass, there's so many times when you say it's an eyeball test and it's maybe 60, 70, who knows. And as you're well aware, the idea for us for choice of conduit, it makes a huge difference for long-term patency. And if it truly is only 50 or 60%, quite frankly, particularly, there's no point in us bypassing it because in a year or two, it's unlikely to be open and it doesn't affect long-term survival. So what can we do to more consistently get FFR for intermediate lesions, patients that are going to get bypassed? We now have convinced radiology, we consistently get assessment of the radial arteries, so we're using them more often, but we can't use additional arterial conduits if we don't have FFR. And then my other question is, philosophically, when are we going to stop doing diagnostic angiography? As it should just be therapeutic. Because as you clearly pointed out, there's way too many negative angiograms. And quite frankly, they frequently, in the absence of another test, really shouldn't be the major determinant of the therapeutic intervention.
Those are both excellent questions. I'll take your second question first, which is, how can we reduce the rate of unnecessary angiograms? In fact, it's so timely that you mentioned that because there's a multi-center trial going on in Europe looking at bypass, patients randomized to bypass just on the basis of CT alone. So they give the CT information to the surgeon as well as the FFR information. And just based on that, the surgeon has to decide where he's going to do the bypass. So it'll be really interesting to see how that trial pans out. But I think the requirement by insurance companies and CMS that if you have an intermediate range stenosis, you need to prove that it is ischemic, either by doing invasive FFR in the cath lab or by having a pre-existing stress test of some sort showing ischemia, or by having CT-FFR, is a very wise decision because it prevents you from unnecessarily revascularizing patients. And there's harm to patients to be had when you do stenting unnecessarily, or, like you said, when somebody puts in a graft in a vessel that doesn't need it, it becomes atretic, and you don't get any survival advantage from that. So it takes time and reinforcement of the data in medicine to overcome inertia. For so many years, we've just thought that if you see a stenosis, go ahead and fix it. And I think it's finally coming around to the concept, well, is that stenosis causing myocardial jeopardy? What is the amount of plaque I'm dealing with in this patient? What other lesions are important? So that's sort of becoming the concept we're heading towards, and I'm so glad you guys are on the same page, because we're partners in this when we're taking care of coronary disease is so rampant. So it makes me sometimes wonder, why did it take us 40 years to come to this concept? We've been doing things wrong the whole time. What have we been doing?
Yeah.
Hi, Dinesh. Hi, Dinesh. This is Sohail Ikram. Can you hear me?
Yes, Sohail. How are you? Good.
Good. I'm good. Thank you very much. So I have a bunch of residents sitting with me here so they all enjoyed your talk also. So two questions on the same FFR, CT FFR. Number one, why is it not so widely available across the country? I hardly see it being ordered. And the second is there a correlation between invasive FFR and CT FFR?
Yes, so both of your questions are fantastic. So the availability is increasing. I think the last time I looked at HeartFlow is the company that gives the FFR at the moment, but there are 7 or 8 other companies that are coming out with their own products. There's more than 1,000 centers across the U.S. that are doing it. I started the process of getting them on board the day I arrived, so we're in the contracting process. We should have that available soon. The relationship between invasive and CT-FFR has been excellent, both in terms of diagnostic accuracy as well as in terms of prognosis and outcomes. That data has come out from at least 4 trials. One of them is DiscoverFlow, which I did when I was back in New York. The other one was NXT, CT-FFR NXT, which is the largest trial that gave the database on the correlation as well as the prognosis. And then there's a real-world registry called Advance that shows you that the incorporation of CT-FFR upstream in these patients allows you to prevent unnecessary caths, better risk stratify your patients, and not have any adverse outcomes. The feeling always has been, well, if you do something and you miss the patient who's going to have a heart attack, we don't want to do that. But once you demonstrate safety of a diagnostic pathway and improved efficiency and throughput and lower cost, then it's an all-round winner. So CT-FFR has been able to demonstrate all of those features now. In fact, if you look at the guidelines, they heavily talk about CT-FFR. As you saw one of the flow charts I showed, if you have a 40 to 90% lesion, they want you to do a CT-FFR. Lesions more than 90% stenotic, that's fairly clear that they're causing downstream ischemia, but a 70% stenosis does not necessarily cause ischemia. Again, it's in the eyes of the beholder. Somebody may say it's 50. And so that's the reason they want you to check and have some sort of ischemia testing before you proceed.
Thank you.
You bet.
Outstanding, Dr. Kalra. And are you able to see the chat area? There are 3 questions there, but I don't know if it'd be toward the bottom. I can read them if you want me to, but they're toward the bottom if you're able to see them.
Sure. So let me start with the first question. Okay, seems like high sensitivity troponin and PST and CCT scan and high sensitivity troponin would give better accuracy and cost benefit. You're absolutely right, Dr. Levinson. That's been tested in a trial called Crescent. And so the combination of high sensitivity troponin and CT gives you the fastest accuracy, shortest time, length of stay. And so that's become part of the guidelines, as you saw. We're moving towards high sensitivity troponin in all cases like that. And then the addition of CT, if it's abnormal, gives you better accuracy and safety. The second question is patients with atypical symptoms, females, minorities, diabetic. Are there any specific changes on EKG to detect ischemia other than the obvious ST elevation? So the EKG, as I told you, is fairly insensitive to ischemia. We've had several patients with horrendous ischemic cardiomyopathy, proximal three-vessel disease, E of 20, who have a normal-looking EKG. So the EKG is helpful if it's abnormal, but if it's normal, it doesn't help you. There is no difference in minorities versus, non-minorities in terms of EKG presentations, with the sole exception being African Americans tend to have different EKG patterns. They tend to have a lot of early repolarization and T-wave inversions, so it's good to be cognizant of that. And your second question was, when would you suspect COVID myocarditis? This is a whole new Pandora's box. I think the problem with COVID myocarditis is, we've had myocarditis with all viruses in the past. We just weren't systematically looking for them. A lot of those tend to be subclinical and they heal, just like COVID does. So if you do suspect somebody with myocarditis, obviously what should prompt the referral is symptoms of chest pain with abnormal EKG or troponin, and then you can do a cardiac MRI to prove it. Most of these people will resolve spontaneously and do fine. Obviously, there's a tremendously small percentage of people who go on to have issues, probably in the range of 0.01%. So it's just, it's been overblown, and the data now coming out from Ohio State and multiple other centers in Europe is very reassuring. And the last question is, let's see, what is the single best imaging test, less radiation exposure? Does it improve or decrease the imaging quality since it's so fast? No, as you saw, Shannon, that you can see atheroma, and the accuracy is fantastic compared to invasive coronary angiography. In fact, the new generation scanner we're going to be getting has a spatial resolution of 0.2 millimeters. So you can see inside the stent. You can see the vessel plaque, so you can characterize what percentage of plaque is fat, calcium, and that's what we're going to be doing. We're tracking non-obstructive plaque over time. So we're going to tell you you have 60 millimeter cubes of plaque today, and down the road it's 64 millimeter. But hey, you know what? 40 millimeter of that was calcified, and now more of the non-calcified has increased, and there's less soft plaque. So we can just quantify for you every little aspect of plaque, which is the direction we're heading in. People forget that plaque progression is perhaps your strongest predictor of risk. If you're a fast progressor, you're at high risk. But stenosis is not the be-all and end-all.
One last quick one. It was kind of sandwiched in there in the chat from Dr.
Okay.
Amaral Carr. Says, what is the next step in acceptance of CT over angiogram / angioplasty to convince IC general cardiologists?
Folks like me and you, we just got to disseminate the data, right? Once you see the data, it's fairly compelling. I mean, it's made it to the guidelines now. I showed you the Scott Hart trial. I think once you get good quality images that you're able to see and say, well, this is a normal CT angiogram, I can stop here. This patient's chest pain is not ischemic. I think it just takes incorporation. There are centers that do 15 to 20 coronary CTs a day. And, we'll get there. I think we'll be able to give you more accurate results next year.
So Dr. Kalra, thank you very, very, very much. I don't know if you realize, but Tom Miller, who you gave accolades to, the CEO of UofL Health, who did listen to you. And I think that's good news that physicians that have the expertise like you and can present the data in a progressive way reach the ears of the administrators that are really actually on our side too about wanting to do the right thing to help the health of the patients that we all serve. So he was on for most of the talk, and I don't believe I've ever seen him on one of our grand rounds. So I thank you very much. Thanks for bringing this technology, and we look forward to hearing in a year or two how this has affected outcomes here in our area with our patients.
Absolutely. Thank you.
Thank you.